First, we have a 32-year-old female who came with complaints of right upper limb pain for the past 2 months. On examination, she was afebrile, BP was 120/80, her systemic examinations were normal, and the left neck examination was also normal. We subjected her to an X shown here. With this history, what do you think will be your clinical diagnosis? What does her X-ray chest show? What are the neurological features of this condition you can think of? And what is its importance and how will you manage her? Next, we have a 54-year-old male who came to the OPD with complaints of palpitation, exertional angina, and generalized fatigue since 1 month. We have a clinical photo of him here. Can you spot the diagnosis? What do you think could be the causes of this condition? How will you proceed to evaluate further? What is Graves' disease? And what are the features of this condition? And how will you manage this patient? Next, we have an interesting ECG here. What does this ECG show? What will be your definitive diagnosis from this ECG? What is short PR interval? What are the causes of short PR? How will you differentiate LGL condition from WPW syndrome? What are the complications you can think of can be associated with this condition? And how will you treat it? Next, we have an interesting ABG of a 52-year-old woman, a known diabetic, who came with left leg cellulitis with complaints of vomiting, breathing difficulty, and tiredness since 1 day. On examination, her vitals pulse rate was 146 per minute, BP was 130/70, respiratory rate was 40 per minute, saturation was 94 at room air. She showed signs of dehydration, blood sugar was 359, urine acetone was positive, and ABG was done for her. And what with this ABG, what will be a diagnosis? What are the findings you can see in this ECG? What does the term euglycemic diabetic ketoacidosis mean? What are the other causes of high anionic gap metabolic acidosis you can think of? And what are the causes of normal anionic gap metabolic acidosis? And how will you manage this patient? Next, we had a 57-year male who's a chronic alcohol and smoker who came with abdominal pain, abdominal distension, nausea, and vomiting since 3 days. On examination, he was afebrile, conscious, and oriented. Pulse rate was 96. For abdomen examination, abdomen was diffusely tender, distended, shifting dullness was present on percussion. With this history, what will be your clinical diagnosis you can think of? How will you proceed to investigate him? An ultrasound was done for him, which is shown here. What are the findings you can see in that? With that, we also subjected him to a CT abdomen. The picture is shown here. What are the findings you can see in that? With this, what will be your definitive final diagnosis? What do you think would be the causes of this condition, and how will you manage this patient? Next, we had a 42-year-old male chronic smoker who presented with complaints of dysphonia, deviation of tongue to the right, and also gave a history of having aspirated 3 days ago. On examination, he had vitals were stable. There was also swelling in the right breast. With this, what will be your clinical diagnosis? The CT image taken for the patient is shown here. What does the image show? What do you think are going to be the causes for this condition? A little bit of anatomy. What is the nerve supply to the larynx? And with this, what will be your final diagnosis, and how will you treat this condition? Next, we had a 2-year-old girl brought to the emergency with a history of having swallowed a gold coin while playing. On examination, the child was active, alert. General examination was normal. An X-ray was taken for her. What does the X-ray show? How will you proceed? And what are the complications you can anticipate in her? Next, we had a 60-year-old lady who came with complaints of fatigue, weight loss, dysphagia for the past 6 months, and a left-sided neck swelling since 2 months. She had no known comorbidities. Her vitals were stable. And we have her clinical picture here. What is the finding shown in this picture? What is Strauss's sign? What is the clinical significance of it here? With this, what can be your final diagnosis? And how will you proceed further, and how will you manage her? Next, we have a chest X-ray of a 32-year-old female who came with complaints of dry cough and breathlessness for the last 3 weeks. It's a known case of pulmonary tuberculosis who had taken ATT 1 year ago for 6 months. She had no fever now. She was afebrile. On auscultation on respiratory system, by the breath sounds were reduced on the left side, was stony dull on percussion. There was a mild tracheal shift to the right. With this clinical history, what is your clinical diagnosis? Then the patient was subjected to an X-ray chest, which is shown here. And what are the findings you can see in this X-ray here? How will you proceed to evaluate her? What is Light's criteria? And how will you proceed to manage her? So thank you. As participants are pondering over the answers for the quiz questions, we shall start our meeting with the prayer, as everything starts with the Almighty. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee. SAH prayer. Almighty Lord, the source of pink health, we submit our heartfelt gratitude for healing the dreadful and the chronic patients through our hands. Bless our Sundaram Arulrhaj Hospitals with all the doctors and staffs. Let them shine up in their effort to heal the sick and develop the science of medicine. We thank you, O Lord, for picking us for this health services to create a healthy longevity for healthy citizen and healthy, vibrant India. Thank you. We shall now start our CME. For the first talk of today will be on drug-induced AKI by Professor Dr. Edwin, sir. We welcome you, sir, to our CPC. I think it's the first virtual CPC you're attending with us. We're so happy to have you with us here today, sir. Dr. Edwin, sir, is at present the professor and head of nephrology, Government Stanley Medical College, Chennai. He's also the academic advisor of Government Stanley Medical College. He's a principal investigator of Credence and DAPA CKD trials. He has received the top researcher award from the Tamil Nadu Dr. MGR Medical University and also the award of excellence from Government of Tamil Nadu on 4 occasions. His special interests are in renal transplantation, renal disease in pregnancy, and AKI. He has published various journals and also in various books. He's also a reviewer in many scientific journals. We are very happy to have you among us, sir. We welcome you, sir. Thank you. We would like you to take over, sir. Thank you.
Thank you very much, Dr. Aarti and Dr. Arulrhaj, for having me here today. It gives me great pleasure to participate in the CME and share some of my knowledge with all of you.
Sir, again, that Firefox wall only is coming, sir.
1 minute.
Yeah.
I think you can see my slides now.
Yes, sir.
Right. So I shall talk to you about the menace of drug-induced acute kidney injury. I bring warm greetings from the Government Stanley Medical College. The kidneys are frequent targets of drug adverse effects. Why? Because the renal blood flow is about 25 to 35% of the cardiac output. High metabolic activity. There's a countercurrent mechanism. So there's an increased concentration in the medulla. Changes in the urine pH can cause intratubular precipitation, and it's an organ with the largest endothelial cell surface area. Who are at increased risk of drug-induced AKI? Advanced stage, congestive heart failure, pre-existing kidney disease, nephrotic syndrome, liver disease, diabetes, malignancy, or somebody's genetic susceptibility. However, there are some modifiable risk factors like how to dose the particular drug, the frequency, duration of exposure, if there is a volume depletion, diuretic therapy, use of multiple nephrotoxic drugs. The treatment of AKI is not yet available, so prevention continues to be the most effective approach. What are the mechanisms of drug-induced acute kidney injury? It can produce an AKI or CKD. It can produce a functional or structural damage, can alter the renal blood flow and the GFR. Drugs can affect any of the 4 histological components: tubules, the interstitium, the glomeruli, and the small blood vessels, and can cause outflow obstruction by crystalluria and papillary necrosis. So these are a few drugs that I have listed. Some of the common ones are hemodynamic AKI with NSAIDs, ACE inhibitors or ARBs, calcineurin inhibitors, and some vasopressors. Tubuloepithelial injury and acute tubular necrosis with many antimicrobials, radiocontrast agents, aminoglycosides, the anti-cancer drugs, cisplatin, amphotericin, the antiviral drugs like cidofovir, pentamidine, tenofovir, and acute interstitial nephritis, any antibiotic could cause, mostly penicillins and the fluoroquinolones. NSAIDs could cause, and more recently there has been a lot of talk about the proton pump inhibitors causing acute kidney injury, H2 blockers, anti-epileptics, even certain loop diuretics. So these are some of the drugs that are very commonly used. So the most common manifestations of drug-induced AKI is, one is an acute interstitial nephritis, other could be an acute tubular necrosis. So how does acute interstitial nephritis happen? About 30% of biopsies performed for acute kidney injury is because of an acute interstitial nephritis, and drugs cause nearly 70 to 90% of all the biopsy proven AN. And in developing countries, it's about 50%, and in developed countries, it's about 78%. 20% cases of unexplained AKI are because of drugs, and incidence of AN is increasing. More drugs, more problems, particularly in the elderly. And even after withdrawal of the offending agent and the treatment with steroids, baseline renal function may not be achieved in a significant number of patients. Most of the pathogenesis is because of delayed hypersensitivity reaction driven by the antigen reactive T cells, or some can be idiosyncratic, not really dose related. Could be the NSAIDs, rifampin, especially the intermittent dosing schedule, and the immune reaction could be T cell mediated or antibody mediated. So the schema is a drug or a metabolite bound to the tubular basement membrane or interstitium, acts as a hapten. There's an antibody response, then there's an immune complex deposition in the tubular interstitium, and this incites an inflammatory reaction. The pathology is very classically tubulitis. There's a lot of inflammatory cells in the tubular wall, the neutrophils in the peritubular capillaries, and you can see the presence of multiple eosinophils. Inflammatory cell infiltrate everywhere, and the kidney looks very congested, a lot of traffic jam there. The clinical presentation, fever, rash, eosinophilia is classically, though described in textbooks, is not seen. One needs a very high index of suspicion. Eosinophiluria, pyuria, WBC casts were previously considered typical, but now are unreliable. So as I mentioned, it requires a very high index of suspicion. So initially, the drugs that were implicated were the sulfa group of drugs, subsequently penicillin and its derivatives, all classes of antibiotics. Rifampin, universally idiosyncratic. We have a paper on rifampin-induced AKI. Beta-lactam antibiotics, most common offenders. They can be associated with fever, rash, and eosinophilia. And the sulfonamides cause AN more frequently in immunocompromised individuals. The other common group of drugs are the NSAIDs. So decrease renal prostaglandin synthesis, increase leukotriene synthesis. So the renal manifestations could be varied dyselectrolytemia, edema due to sodium retention, hypertension, decreased GFR can produce a minimal change or a membranous nephropathy and produce a nephrotic syndrome. That is generally AN due to NSAIDs have a relatively long latency period. The inflammation is muted, systemic manifestations are rare. Granulomas and eosinophils are rare. Recovery of renal function may take months after discontinuation. The proton pump inhibitors, again, a very commonly used group of drugs, not only by physicians of any specialty, but also by patients themselves over the counter. Worldwide now, it's been thought that this is increasing progressively. Omeprazole AN was identified in 1992. Now there is a talk that it could lead to CKD also. After the antibiotics, now it is assumed that the second most common cause is going to be your PPIs. So again, here, the latency period is 1 week to 18 months. Older patients are at higher risk. Poor metabolizers of the CYP3A4 pathways, polymorphisms are at increased risk, and PPIs related interstitial nephritis has fewer systemic symptoms. And if there are other antibiotics or NSAIDs used, the chances of somebody developing a lesion are more common. Can present with acute or chronic renal failure. And most times the creatinine does not return to baseline. The H2 blockers are also linked to AN, but do not cause CKD. So Elderly patients are the groups that are more commonly affected. Penicillin and omeprazole are the most frequent offenders. Early kidney biopsy should be considered because it will help you to start steroids. So what is the management? Varied clinical presentation, divergent response to culprit drug discontinuation alone. No definitive treatment. You must recognize an early drug withdrawal is imperative. Some patients do respond well to just discontinuation of the drug, while longer duration of exposure is associated with worse chance of recovery. The unanswered questions are: what is the role of kidney biopsy to establish diagnosis and the utility of steroids in the management? Steroids have been used. However, there are no RCTs to really prove. So some of it are retrospective studies. There are some studies that support the use of steroids, while some say there is no much difference. But we would say that if we are able to do an early biopsy, show some granulomas or interstitial nephritis, a short course of steroids of about 4 to 6 weeks could be tried. If there is significant chronic changes on the biopsy, then there's no point in exposing this patient to steroids and the possible side effects because of this. Who should get steroids? As I mentioned, somebody who should not get steroids, rather. Poor response to steroids with interstitial fibrosis and tubular atrophy. And somebody's got, let's say, diabetes with active infection, labile blood glucose. Better to avoid steroids in this group of patients. Better outcome is observed when the steroids are started quite early, 1 to 2 weeks of recognition. And what is the pulse therapy of methylprednisolone? And then maximum 4 to 6 weeks could be tried. So the most important thing is to suspect and withdraw the offending agent and then provide supportive care. If the kidney function improves, well and good. If it is not improving, probably look at a biopsy. If the biopsy is showing more than 75% of chronic interstitial changes, then it's conservative management. If it is less than that, and if there's no contraindication to steroid dose, you could probably try steroids. The other pathology is acute tubular necrosis that commonly happens with aminoglycoside, again, a very commonly used antibiotic. Vancomycin, IV contrast, again, very commonly used. NSAIDs, rifampin, cisplatin, amphotericin B, colistin, polymyxin B, all this can produce an ATL. So some unique features that aminoglycoside induced AKI is non-oliguric and associated with hypomagnesemia. Amphotericin B with tubular dysfunction, hypokalemia, hypomagnesemia, and rifampin often accompanied by thrombocytopenia, anemia, and altered LFTs. Aminoglycosides primarily affect the tubular epithelial cells. The risk increases with higher peak serum levels, higher baseline renal function, longer duration, poor renal perfusion, concomitant nephrotoxins, old age, diabetes, cirrhosis, and longer duration of treatment. Cumulative exposure increases the risk of nephrotoxicity. It is recommended to use extended interval dosing to minimize AKI and inhalation aminoglycosides when applicable. Of this, the neomycin is the most nephrotoxic and streptomycin is the least nephrotoxic. Amikacin is relatively safe. Genta and tobramycin are the next in line. Contrast-induced AKI. Remember that all contrast agents are triiodinated benzoic acid derivatives and are highly water soluble. So now we use mostly iohexol, which is a low osmolar, or the isoosmolar, which is approximately about 290 milliosmol. That's almost akin to the plasma osmolarity. And higher the osmolarity, greater the vascular symptoms. When do you suspect a contrast-induced AKI? You must definitely check creatinine 24 to 48 hours after contrast exposure. Whether the novel biomarkers are really helpful is not very clear as of now. So again, what the best thing is to prevent. There is no contraindication. If you think a contrast study is going to help the patient, we'll have to go ahead with the study. So use a low volume as possible, low osmolar contrast agents or high isoosmolar agents. Always look at volume expansion of the isotonic crystalloids. There's no adjunctive therapy. Some studies have used statins. NSAIDs and metformin may increase the risk of contrast-induced AKI. N-acetylcysteine is of not much of use. Vancomycin is commonly used in the ICU as well as in the dialysis units. Its detrimental oxidative effects on the proximal tubular cells are a problem, and toxicity is directly proportional to the trough levels. Ideal to use therapeutic drug monitoring in this group. And of course, if there are concomitant nephrotoxicity agents, it increases the risk. And this is something that all of us face, mostly nephrologists face. Non-allopathic medicine induced AKI. Several traditional medicines containing toxic heavy metals. We have had very bad experience with mercury, very high levels of mercury, arsenic, producing AKI, also producing CKD, some of them producing nephrotic syndrome. The fairness creams that contain mercury have been implicated in the proteinuria. Papers have come from this part of the country, where it is found that high levels of mercury in the fairness creams have produced glomerular damage. And many of renal failure patients, after the first consultation with the nephrologist, always go to these non-allopathic medicines before they come back with worsening kidney function back to us. So, as I said earlier, there's no specific treatment. Treatment is only expectant line of management. Very, very important to look at prevention. Nephrotoxin should be used judiciously. Recognize and correct precipitating factors like hypovolemia, limiting the cumulative dose, and use less toxic alternatives like liposomal amphotericin instead of the conventional preparations, and using less nephrotoxic aminoglycoside. Avoid combination nephrotoxic like NSAIDs and ACE inhibitors, cisplatin aminoglycoside. Avoid polypharmacy. Adjust dose according to physiological state and renal function. Therapeutic drug monitoring, if available, is very useful. We do use therapeutic drug monitoring for cyclosporin and tacrolimus in our transplant patients. And very, very important to monitor for nephrotoxicity. Look at the urine, look at the creatinine and the electrolytes. So this is the framework of drug-induced nephrotoxicity. Look at risk assessment, early recognition, targeted response, timely renal support, rehabilitation, and then research. So this is the International Society of Nephrology motto, 0 by 25, which means that nobody should die of preventable and treatable acute kidney injury by 2025. Let me conclude by saying that drug-induced AN is increasing in incidence, especially among elderly. PPIs have emerged as a major cause in addition to antibiotics and NSAIDs. Wide availability and the use of NSAIDs and PPIs, especially in a country like ours where there's a lot of over-the-counter prescription, this is not likely to decrease in the foreseeable future. Many of the medications produce only subclinical or subtle presentations, so a very high index of suspicion is required. Early kidney biopsy may be necessary, which may help with steroid therapy. And if the recognition is done early and the drug is withdrawn early, the recovery is faster. So I'm reminded of the words of Voltaire, a very famous French philosopher during the French Revolution, who mentioned that doctors use drugs of which they know little onto patients of whom they know less for diseases of which they know nothing at all. Thank you for the very patient listening. I'll be happy to take a few questions at the end. Thank you very much, Arulrhaj sir and Aarti, for the opportunity given.
Thank you, Dr. Edwin, for a comprehensive presentation of this important clinical problem. Every day in and out, we see this. Not only doctors giving medicine, patients, over the counter sale. Okay. Every time they say they go for a back pain or a neck pain or a headache and take a drug and then come to the pedal edema. Immediately we can make a diagnosis. It is a drug-induced nephropathy. Yes. And I'm so happy you have conveyed the causes of drug-induced nephropathy in a different way. We all know NSAID is common. Our contrasts are common. But omeprazole, we have stressed so much, proton pump inhibitors, especially omeprazole, because every patient we add a proton pump inhibitor, every drug, especially those who are taking it for a long time. And antibiotics also, we know streptomycin, this and that, aminoglycosides. But now, penicillin and all other antibiotics, I'm thankful to you. All the audience will definitely be benefited by this, important communication. I'm sure so many questions is awaiting to you. And
Yes, sir.
I too would like to listen to your, answers. Thank you. Thank you so
Thank you,
much.
sir. Thank you, sir. Thank you,
Personal
sir.
regards to you.
Thank you, sir.
Thank you
Audience
so
will have to shoot Dr. Edwin. It is very difficult to get at him.
Thank you so much, sir. That was a highly excellent and informative talk for us today, sir.
Thank you, sir.
Um,
Thank you,
uh,
Edwin.
I think Subhashri ma'am will have something to ask Professor.
I have taught her everything.
Yeah, she has put in the box as awesome talk as always, sir. That's what she has put. Delegates, you can unmute yourself and ask your queries, or you can drop it in the chat box. We can take it up. I think it was actually crystal clear, sir. Very clear what we should use, what we should not use, how we should suspect. I don't think they will have much doubts on that. If there are any questions, we'll have it even after the second talk, sir. Sure.
What I would suggest is to go by the GFR, especially if you're looking at elderly people.
Okay, sir.
Because what happens is that the normal GFR in our population, it's not as it is described in the textbook, 120 ml, no. Most of our population have only a GFR of 90 ml. This we have seen because when we work up all the prospective kidney donors, when we look at their GFR, there's only about 90, maximum 100. So what happens is after the age of 40, the GFR starts dropping by 1 ml per minute per year. So if you're born with a GFR of 90, by the age of 60, your GFR is only 60. But this will not be reflected in serum creatinine. This is the biggest problem. Because as a nephrologist, I do not have authentic measure of GFR, which I'm supposed to have. So I go by serum creatinine, which is the one that is available. I have to live with serum creatinine. Serum creatinine came into existence in 1885. Till 2024, we are still stuck with serum creatinine, though there has been a lot of talk about cystatin C. But however, that test is quite expensive and it is not possible in day-to-day setting. So the serum creatinine does not essentially reflect the GFR. Now that you have, all of us have Android phones, you can look at the MDRD calculation or the CKD-AP calculator that is available on the Android phone. You need only the serum creatinine, the age of the patient to be fed into that calculator, and it will give you a GFR. Now, if you take any textbook or any book, there is an appendix at the end showing how the drug can be modified for this particular GFR. So generally, what we do is we give gentamicin 80 mg BD, amikacin 500 mg BD for everybody. But if you go by the GFR, we will be able to give the appropriate dose for the GFR. In that way, we can be preventing nephrotoxicity. So this is something that is easily available. And today, we can, in front of our patient, we can say, I'm not sure about the dose, let me check and then give you the dose. I don't think that's a great harm. Dr. Mani, our senior nephrologist, used to say there's nothing wrong in referring in front of a patient. And now that patients also read Google and what is wrong, it's not possible for us to remember everything. And since in the age of Android phones, I think everybody should follow the GFR, especially in the elderly age group. Somebody over 60, I think better to go by the GFR, not by the creatinine. So
if it is less than 90, you're not advising us to use this amikacins or gentamicin?
No, it can be used, madam. Suppose there is a Klebsiella UTI that is sensitive only to amikacin and the patient is in urosepsis. You can't say, I will not use amikacin. I will use some other drug. But then go by the GFR. Look at the dosage of amikacin.
If the GFR is less than 90, then can we use it then?
No, most of us have GFR less than 90 only.
Okay.
You can check your GFR. There is no authentic way of looking at the GFR.
Okay. Then is there
something? So that is why these formulas are there. These formulas have been validated in all populations. Okay. So it is also validated in our population. So just look at CKD-AP 2021 equation. You just put it on Google. That calculator will come. So it needs only two metrics to be fed in. One is the creatinine, other is the age and the sex. And you get a GFR. So with that GFR, you can actually know this is the real GFR. The creatinine may be normal. So again, I want to drive the point that serum creatinine does not essentially reflect the GFR. The serum creatinine, we see all our kidney donors who have donated kidney 10, 15 years back. You look at their creatinine is only 1 milligram. They have lost 50% of their organ, but still the creatinine is only 1 milligram.
And I think
So that
you
is
have
why
also
today
answered the
modern
question.
labs, you will see that they will give the creatinine, also give the eGFR. So this is eGFR. There is estimated GFR. There's no way of measuring the exact GFR. That can be done only by inulin clearance, which is not available to us. It's not available at the bedside.
Thank you, sir. And I think you have answered one of our colleagues, Dr. Kailasam sir's question also, which eGFR formula is standardized, sir.
Yes.
So I think
There are
you have answered
two
that
formulas
too.
that you have to remember. One is the CKD EPI 2021 equation. So this is validated for everybody who has got a normal creatinine. If you got somebody with a CKD, then better to use the MDRD formula. So if the GFR is less than 60, use the MDRD formula, modification of diet and renal disease. So that is also available on Google. You can just put that calculator and calculate the GFR.
Thank you so much, sir. As of now, we don't have more questions in the chat box. We thank Professor Dr. Edwin sir for his excellent talk. And we shall now move on to the second talk, which will be a case discussion on a challenging case of dizziness, which will be presented by a final year DNB postgraduate, Dr. Dhinesh, and discussed by our interventional cardiologist, Dr. Neelamjan sir. Over to you, Dhinesh.
Good evening. Good evening, everyone. I'm Dr. Dhinesh Kumar, final year DNB postgraduate. Today, we are going to discuss about a challenging case of dizziness. So, coming to the history, a 65 years old male presented with complaints of 3 episodes of dizziness since last 2 days. There was no history of headache, nausea, vomiting, photophobia, phonophobia. No history of weakness of limbs, loss of consciousness. No history of chest pain, palpitation, sweating, or arm pain. No history of breathlessness, orthopnea, PND. Past history, the patient is a known case of diabetic for the past 5 years on regular treatment. And personal history, the patient was not a smoker or alcoholic and consumes veg diet. So the clinical possibilities include coronary artery disease, acute coronary syndrome, or posterior circulation stroke, seizures, pulmonary embolism, or sinobronchial syndrome. So coming to the examination, on general examination, the patient was well built and well nourished. There was no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Vitals, temperature normal, BP 80-60 mmHg in the right upper limb in supine position. Pulse rate was 105 beats per minute. Respiratory rate 18 per minute, thoracoabdominal and regular. Systemic examination, CVS examination, S1 cleared and there was a loud P2 and there was no murmurs. Respiratory system, normal vesicular breath sounds and bilateral air entry were equal. Central nervous system, there was no vocal neurological deficit. Abdomen soft and no aranomegaly or no buoy were here. Coming to the investigation, the HP of the patient was 11.2. TC, DC, ESR, everything was within the normal limits. And the blood sugar was 343 with a HbA1c level of 8.3. The urea creatinine, lipid profile, and other routine investigations were normal, including the CT brain, EEG, urine routine, liver and liver function test. TRAPE was also within the normal range. And the ECG showed sinus tachycardia. And the echo showed a LVEF of 60%, mild concentric LVH, and severe pulmonary hypertension, severe TR, and LVDD. Initially, we thought the pulmonary hypertension was because of idiopathic pulmonary hypertension, and we didn't evaluate much for the pulmonary hypertension. So the patient initially started on antibiotics, antihistamines, and insulin for sugar control. On day 2 of hospitalization, the patient developed difficulty in breathing. On examination, the vitals were 80, BP was 80/60, pulse rate was 123, sinus rhythm and regular. The respiratory rate was 40 with a SpO2 of 80% at the room air, but the systemic examination was totally normal and the ABG was normal. And we did a D-dimer in view of difficulty in breathing, which was around 3,433. And the chest X-ray showed a prominent right descending pulmonary artery. And the follow-up echo showed dilated RV and LV collapsed with IV dilated and non-collapsible. So in view of elevated D-dimer, we did a CT pulmonary angiogram, which showed acute pulmonary thromboembolism, which showed partial lumen occluding thrombus in the distal part of right and left pulmonary arteries, bilateral superior and inferior lobar arteries and their segmental branches, causing 7 to 80% luminal compromise with right heart strain. So this is the CT pulmonary angiogram image. Here you can see the main pulmonary artery with right and left pulmonary artery. There is a filling defect seen in the left pulmonary artery and segmental branches, which indicates pulmonary embolism. So the diagnosis was made as acute pulmonary thromboembolism and diabetes mellitus. So the patient was treated with thrombolysis with injection Alaxim 30 mg IV. Injection Avil and Hydrogat were given prior to the thrombolysis. So after the thrombolysis, the patient was started on Lupinac 60 mg BD for 5 days and tablet sildenafil 25 mg for pulmonary hypertension. After 5 days of low molecular weight heparin therapy, the patient was started on newer oral anticoagulant tablet apixaban 5 mg. Together with that, patient was treated on insulin and OSA for diabetic control. So to find out the cause, we did a serum fibrinogen, serum homocysteine, and protein C, protein S level. Everything were within the normal limits. But the venous Doppler of the both lower limb showed right lower limb DVT involving the popliteal and soleal veins. So the final diagnosis was made as acute pulmonary thromboembolism provoked by deep vein thrombosis of right lower limb and diabetes mellitus. So the follow-up CTPA showed decrease in the extent of bilateral pulmonary arterial thrombus and mild decrease in the size of dilated RV and RA. The follow-up echo showed EF of 65%, mild TR, mild pulmonary hypertension. RV was normal, IVC was non-dilated and collapsible. So goes in the hospital, a 65-year-old male presented with complaints of 3 episodes of dizziness for the 2 days, initially treated as query seizures, a sinobronchial syndrome, and developed respiratory distress on the second day. CT pulmonary angio showed acute pulmonary thromboembolism secondary to right leg DVT, thrombolyzed and started on low molecular weight heparin, followed by newer oral anticoagulant, and the patient was discharged in a stable condition. So this is the case 2 which we had yesterday, a 32 years male, known case of DVT. 1 month ago, last follow and presented with complaints of breathlessness for the past 2 days, and ECG showed sinus tachycardia, echo showed dilated RA and RV. CTPA showed pulmonary thromboembolism of interlobar artery, thrombolysis, and now the patient is started on low molecular weight heparin. So coming to the discussion, pulmonary thromboembolism is a blockage of an artery in the lungs by a substance that has moved from elsewhere in the body through the bloodstream, mainly blood clot. A small proportion of cases can be due to air, fat, or amniotic fluid. The symptoms include shortness of breath, rapid breathing, chest pain, mainly pleuritic type, cough, hemoptysis, and cyanosis. The dizziness can occur mainly due to reduced cerebral perfusion. The signs include pleural friction rub, audible over the affected area, and pleural effusion, sometimes that is usually exudative. Strain on the right ventricle may be detected as parasternal heave, loud pulmonary component of the second heart sound, and raised JV. A low-grade fever may be present, particularly if there is associated pulmonary hemorrhage or infarction. Large pulmonary embolism, which tend to lodge centrally, typically cause dyspnea, hypoxia, low blood pressure, fast heart rate, and fainting. The risk factors, the main risk factors are those who undergo orthopedic surgery at or below the hip without prophylaxis, pancreatic and colon cancer patients, with pregnant women, those who are on estrogen medication, obesity, cancer, and catheterization causing direct injury to the endothelium. Factors affecting the properties of blood, that is procoagulant state, which include estrogen containing medication, genetic thrombophilia like factor V laden mutation, prothrombin mutation, protein C, protein S deficiency, antithrombin deficiency, hyperhomocystinemia, plasminogen, and fibrinolysis disorders. Acquired thromboembolism, thrombophilia, antiphospholipid syndrome, nephrotic syndrome, paroxysmal nocturnal hemoglobin. So coming to the risk scoring for pulmonary thromboembolism, which is Wells criteria. If the score is more than 2, it indicates clinical high probability of DVT. If it is less than 2, it is the DVT is unlikely. So coming to the diagnosis of pulmonary thromboembolism, the first blood test, the D-dimer, which is the most commonly used in clinical practice, but the main use of D-dimer is mainly to rule out the pulmonary thromboembolism. If the D-dimer is negative, we can confidently say that there is no pulmonary thromboembolism or DVT, and there is troponin levels which can be increased between 16 to 47 patients per person patients with pulmonary embolism, which is mainly due to the artery strain. And ECG will show sinus tachycardia. The sinus tachycardia is the most common finding in a pulmonary embolism patient. Even though we say S1 Q3 T3 pattern, which is only seen in 20% of patients with pulmonary embolism. So the chest X-ray will show Hampton's sum, which is a wedge-shaped opacity with the base towards pleural due to pulmonary infarct. Fleischner sign, which is prominent pulmonary artery, and Westermarck sign, which is a pulmonary oligemia. So coming to the echo will show RA-RV dilation in massive pulmonary embolism. Echo may be normal, even normal and mild or submassive pulmonary embolism. And there is the McConnell sign, which is there is a entire hypokinesia of right ventricle, but the apical portion of right ventricle will show hypercontractility, which is because the contraction of the left ventricle pulls the apex of the right ventricle. That will be seen as a hypercontractile apex of the right ventricle. So, and the investigation of choice in suspected case of pulmonary thromboembolism is CT pulmonary angiography, which will show filling defect. So this is your aorta and this is your pulmonary artery. The pulmonary artery here shows usually the aorta and pulmonary artery are in equal size. But in pulmonary thromboembolism, the pulmonary artery will be dilated and the pulmonary artery will show filling defects, which indicates pulmonary thromboembolism. And finally, we can do VQ ventilation perfusion scan, which is very rarely done whenever you cannot do CT pulmonary angiogram, like for pregnant females, for dye allergy, or if there is elevated urea creatinine. In those settings, we can go for ventilation perfusion scan, which will show normal ventilation with reduced perfusion. And coming to the treatment, thrombolysis, the thrombolysis, it is mainly done in massive pulmonary embolism with hemodynamic instability. And it's also done in a selected cases of submassive pulmonary embolism. It can be a direct thrombolysis or catheter-directed thrombolysis. And pulmonary thrombectomy, it is mainly done for patients with high bleeding risk in whom we cannot go for a thrombolysis like subarachnoid hemorrhage or history of hemorrhoids, bleeding PV, UJ bleed. In those cases, we can go for pulmonary thrombectomy, which can be surgical or catheter-based thrombectomy. And for anticoagulation, usually we will give low molecular weight heparin for the 5 days and followed by newer oral anticoagulants. And if there is a history of DVT or recurrent pulmonary embolism, then we can go for IVC filter to prevent the embolism from DVT. So why this case is presented? It is a case of dizziness on examination. Patient had loud P2, patient developed dyspnea on second day. D-dimers were high, CTPA showed pulmonary embolism. We thrombolized the patient. We started on low molecular weight heparin, followed by newer oral anticoagulants, and the patient discharged in stable condition. So take-home messages: all dizziness are not due to BPPV. Loud P2 evaluate for cause of pulmonary hypertension. Keep DVT and pulmonary thromboembolism in atypical presentation. And few more clinical points that I would like to mention, that in any patient presenting with acute onset dyspnea with reduced saturation levels, and in examination, you don't find any clinical signs like V's or CREPS, usually suspect pulmonary embolism. And in examination, even around 50 to 60% of patients with DVT will have normal examination. So the clinical examination is usually highly misleading in DVT. So always in any case of suspected DVT, always do venous Doppler. And D-dimer mainly used to rule out pulmonary embolism rather than for ruling in pulmonary embolism. Thank you.
As Dr. Neelamjan sir could not join, we request our chairman sir to discuss this case and also the quiz questions, please.
I should appreciate our Dhinesh Kumar, who is entered into the final year, for his excellent presentation of these cases. I am sure with these clinical efforts, he will do well in his final year examinations. See, the problem here is somebody has come to us for some breathlessness and dizziness, that's all. It is not for a chest pain or a arm pain or a leg pain, nothing. Only dizziness. Commonly, we think it is due to a sinusitis or a vertigo or, some other, positional problem. But here, these cases tell us that it could be due to pulmonary thromboembolism. As in the summary, Dhinesh Kumar said, when somebody comes to you with some breathlessness, it can be either cardiac or pulmonary. It can be a COPD or it can be a cardiac left heart failure. Always you should think that it could be pulmonary embolism. Everything is normal, but still patient is breathless and little cyanosis is there, some sweating is there. And I used to focus on pulmonary second sound, P2. When P2 is loud, we should always suspect. And immediately I will recommend a D-dimer to be done, take 30 minutes. When it is high in thousands, we should know that it is due to a pulmonary thromboembolism. And always an echo helps us, a right side dominance, dilatation, and the pulmonary artery either side may be, prominent. Sometimes there may be a wedge-shaped, pulmonary infarct with the base on the pleural side of it. These are all points that are available. ECG shows S wave in lead 1, Q3, T3. All these things are possible. Or a right ventricular dominance, tall R wave. All these things are possible. But the final court of appeal is only a pulmonary angiogram. And CT angiogram always tells you whether there is a pulmonary thrombus or not, infarction or not. If it is there, it is there. And always, it is a very good test. We should do that. As we were preparing for this case, last night we had another case. And he was having a breathlessness, ECG, everything is normal, young chap, and he had it, and he had a DVT long term. Now the message here is, anybody with breathlessness or dizziness or sweating without proper cardiac and ECG shows no infarction. X-ray does not show any COPD. Always consider it could be pulmonary thromboembolism. Immediately you can do a D-dimer, an X-ray chest, ECG, echo, and if need be, a CT angio, we will be able to make a definite diagnosis. Never forget the source. The pulmonary thrombus can take place in the pulmonary artery itself, but always it is a thrombus from lower down. That is why we need to look at the legs, very commonly legs, and it slowly migrates and gets into the pulmonary artery, get locked there. And in previously one of our cases who had both sides legs, DVT, he had some thrombotic condition that we treated. Finally, we inserted an IVC filter. See, from the legs, the veins come to the inferior vena cava. From there, it goes to the heart and goes to the right side. If we block it in the abdomen by putting a filter through the IVC, we will be able to prevent the pulmonary thromboembolism. Therefore, friends, never forget thromboembolism. A simple thrombolysis, either intravenous or intraarterial or a thrombus, anything can be done. Even a simple heparin will be able to control and save the patient. And I again appreciate our postgraduates who have done a good job. I think next we need to go to the last segment, Aarti.
Yes, sir. We can go on to the quiz questions.
Any queries on this?
No, sir. Not as of.
Why they don't ask queries of participants? It is only 10 o'clock, not yet very late. Why none of the other postgraduates also don't have any queries? They have sorted out all their queries, it seems.
Rajan sir, you can ask a few questions on that, on pulmonary embolism, please.
Rajan is there.
Dr. Rajan sir from Pudukkottai, he's here. Professor Rajan sir.
Yes, Rajan.
Sir, please unmute yourself.
You can share your experience also.
Sir, please unmute yourself, sir. Sir, unmute பண்ணுங்க.
Share போடுங்கடா.
Digital team, Dr. Rajan sir, unmute பண்ணுங்க. Sir, you are not audible, sir.
Madam?
Sir, இப்ப கேக்குது sir. Yes, sir.
Sir, as Professor Arulrhaj sir told, we come across then and there always. I'm very keen on doing a dimer and CT pulmonary angio so that we can succeed. Thank you for your excellent presentation and thank you for remembering us that the Dizziness is not always easy. Thank you, Professor Arulrhaj sir.
Thanks, Rajan. Thanks,
Thank you,
Rajan.
sir.
Yeah. Now we'll go over to the final segment of our CPC today. There. The clinical discussion of it. We have a very few important clinical material here. First one is a 32-year-old female who came with a right upper limb pain. We were evaluating when there is a right upper limb pain or a limb pain, you will have to think for any neurological cause or vascular cause. And always you check the pulse, vascular cause is done. Neurological cause, you do a neurological examination, cause is done. And in the upper limb, there can be any causes, cervical spondylosis, anything can be there. But simple and X-ray chest taken in a good way can tell you that it is a cervical rib. You see here an extra rib here. All these transverse processes are upturned when there is a, rib coming from the lower, low turned, transverse process. It is a definitely a cervical rib. This causes here, there is a, it compresses upon the nerve system, causes pain. And the message here is when you find an upper limb pain, always that is neurological, try to rule out a, cervical rib by taking a simple X-ray chest. Here is a 54-year-old man with COPD. He came with palpitations, excessive angina, and some fatigability. If you can see the face, you will be able to make a diagnosis. He has prominent eyes. He has prominent eyes. And eyes have been pushed forward. That we call it as exophthalmos. And you see here, sorry. If you see here, the eyes are prominent. This eye is looking forward. This eye is having a lateral deviation, divergent squint. You see here it's called as a exophthalmometer. By we are able to measure the amount of, eyeball which has been pushed up. I used to say clinically, when the limbus upper side is seen, we should always think that it could lower side may be seen often. Upper side seen, always consider it is an exophthalmos. It could be due to many causes. Can be due to local causes in the orbit or central causes, but commonly you look at the neck and count the pulse rate. There is a tachycardia or the neck swelling of thyroid, exophthalmos, it is Graves' disease. That always you will have to think and you will start evaluating, put him on some drugs like carbimazole, it comes down very well. And here is an ECG. A routine ECG was taken. Patient is not very much symptomatic also. But here, if you see this ECG, this is the P wave. This is the QRS. This is ST segment, this is T wave. You see the PR interval is very much shortened. But QRS, everything is normal. This is, here you see the PR interval is very much shortened. Not, 0.12. It is very much less. We call it as LGL syndrome. Levin syndrome. It is a short PR interval. It is prone for tachyarrhythmias. The latter stage can be atherosclerotic, can be congenital, can be an electrical abnormality. If you want to know, probe further, you will have to, go for ventricular conduction defect studies. And if your patient is symptomatic, you will have to do an ablation of the aberrant pathway. There will be an aberrant pathway in these people. LGL syndrome indicate accessory pathway. Here is somebody, 52-year-old man. So diabetic, not very much control, and had some breathlessness and vomiting and a sign of an infection in cellulitis. Without seeing the patient, you can say diabetic, signs of infection and breathlessness and vomiting. It is usually due to a diabetic ketosis. And when you do an ABG here, there is a high anion gap metabolic acidosis. And here is, you see his blood sugar. This is I'm very much within the limit. There is an entity called euglycemic diabetic ketoacidosis. It can occur as such. It can be due to some of the newer drugs like the glyphosins. Therefore, you must be aware of it. We are known for diabetic ketoacidosis, hyperglycemia, and then acidosis, hyperkalemia. Patient is in breathlessness, Kussmaul's breathing, but here also it can be there. You will have to take care of the electrolyte abnormality and the acid-base difference, and we will have to correct it. A non-ketotic coma can always be there. We should be aware of it. Somebody having pain, abdominal pain recurrently, gives a lot of money to the government back through the TASMAC. Alcoholic, abdominal pain. You may think it is gastritis, patient may say it is gas, but always as clinician we should suspect pancreatitis. Simple, ultrasound can show you enlarged pancreas, head, body, tail is very much enlarged. CT is also very, very useful, can tell you any blockage in the vessel system also. Therefore, recurrent pancreatitis, always think about alcoholism and make him to come out of it. See here, somebody has come, a male smoker, has come with a hoarseness of voice. You see this video, this side is not moving, it is also enlarged. And if you take this patient's CT, there is a large mass here, large bronchogenic carcinoma in the upper lobe, which is compressing over the, 10th nerve, which causes this problem. Can be due to many other causes also, Lyme disease, myasthenia, but usually you consider that it is a 10th recurrent laryngeal nerve obstruction in the neck, either due to lymph node or a mass, and come down a little, you will be able to see a mass in the lung. Then it is a hoarseness, always suspect vocal cord palsy. Don't think that it is due to long shouting or a laryngitis. Think it could be paralysis. Simple. Ideal, you will go to, make it up. I think you are able to see it now. Now this is a small child. Swallowed a gold coin. Mother and father were very much attached to the child. They gave gold coin to the child. Gold. And the child swallowed it. And you see it here, a ring. And it was removed by our gastroenterologist. Always intervention is good. Any specialty of internal medicine, whether it is cardiac, gastro, neuro, nephro, intervention is the order of the day, always rewarding. This ring has been taken out and the parents are so happy, child is relieved of it. This is a clinical scenario. A lady, 60-year-old, has some systemic symptoms, but you see here, supraclavicular. There is a big mass here. It is a lymph node. Always think that there will be some malignancy in the GI system or in the lung. She has a dysphagia. Immediately do a gastroscope. We were able to make out a growth involving the distal esophagus, and abdomen showed a lot of liver metastasis. And the biopsy also proved it is malignant. She is on palliative radiotherapy. Always suspect when there is a supraclavicular, whether it is a virtuous node here or a simple supraclavicular node here, think that it could be malignant. That's why we are able to save the patient. This is a 32-year-old female, had some cough, some tuberculosis and sputum, and had taken about 1 year ago for tuberculosis for 6 months, probably an intermittent. She has now come with dry cough and breathlessness. See the X-ray, entire left side is totally opaque, large pleural effusion. See the mediastinum, heart, everything shifted to this side. This side dome is high, this side dome is totally low. This shows a large fluid collection on the left side, pushing the mediastinum to the opposite side. Massive pleural effusion. Take out an aspiration, send it for analysis. It comes also as an executive. Do a, ADA and it is positive, CB-NAT is positive, proving tuberculosis. Usually after aspiration anti-tuberculosis therapy, it settles down. If it is not settling down, you will have to do a fluorodesis, either through putting an ICD or putting a, thoracoscopy we need to do. Reactivation of tuberculosis, always consider. Just because he or she had anti-tuberculosis therapy, it is not right. Never wait for sputum AFib. Now molecular tests are available to clinch the diagnosis. Let us proceed into it. I am thankful to all the participants of today's CPC. Sure, we will have a lot of, mind-boggling clinical situations in future. All of you can bring it out in the next meeting. We will have it in December. Thank you. Thank you all very much for your support and active participation. Thank you. Thank you. Thank you, sir.
Thank you.
Thank you, sir, for your valuable clinical discussion. We thank all our colleagues once again, and let's all meet again next month with another few more interesting clinical discussions. Till then, stay safe and healthy. Good night to one and all. Thank you, Edwin, sir. Thank you so much. It was an excellent session we had today, sir. Thank you so much.
Thank you. Thank you, Aarti. Good night.
Yeah,
It is.
என்ன தொந்தரவு தெரியுது
Chest pain.
எந்த இடத்துல வலிக்குமா எத்தனை நாளா இருக்கு
இப்போ 3 days ஆச்சுக்கலாம் இதே ஜெயிக்குது ஈவினிங் வந்த உடனே
ராஜ கட் பண்ணாம இருக்கான்
இதுக்கு முன்னால நான் இடையிடையே சொல்லுவான் நான் ஏதாவது கேஸ் கொஞ்சம்